All right. Hello again, and welcome to another Down Fracture podcast, a podcast for talking jaws. Downfracturepodcast at gmail.com. We again got some more emails and other things that were useful, things we'll talk about in the future going forward. Sam, it is 3 days before Christmas. Are you ready?
I think I'm feeling pretty good about it. I've got I think I've got all my shopping done. I don't know if I have much
But
time. What about
do
you?
you feel, would you describe yourself as having the quote unquote Yuletide spirit? Or are you not there yet?
Ooh, I mean, I had the Christmas pants out in clinic last week, and that helped improve my Yuletide spirit. So maybe one more day of Christmas pants will push me over the edge. It's just
This
kind
is
of busy time. So,
it's kind of amazing how much pants influence our perception of what's going on.
pants.
Like a good pair of pants can really be the difference in a good and a bad day, a festive or a non-festive individual.
Man, pants do. I got turned on to Christmas pants by there's an ENT surgeon. He's a head neck surgeon. His name's Joe Sneezek. And when I started working at the hospital, the administrators pulled one of those, oh yeah, you have a clinic, it's all ready to go. And then when I showed up, it was someone else's clinic and they were all shocked to see me. And so my office was nice enough to be in his like somewhat closet. And so we would just hang out and I found out about Christmas pants and he had some nice like fitted corduroy pants. And so I got turned on to Christmas pants then and I thought it was great advice. It's a good measure to gauge how much weight you've been gaining every year. You
Yeah.
just tighten them, you put them on and you the advice to order them a couple sizes too big at the beginning is sage advice. And I think they bring the Christmas spirit with them. So I feel like getting a lot of years out of them. Do you have any?
I have a lot of like Christmas PJs. That's short for pajamas.
Okay.
And
You seem like that kind of guy.
I wear those just like with my kids. We had a neighborhood Christmas party. I wore them like they're like elf pajamas. Uh, and then I'm more of a socks guy. Like I wear
Uh,
seasonal and amusing socks. Like today, I'm wearing a pair of socks that says "Call me old fashioned," and it has a picture of a beverage old fashioned on it.
I see what you're doing.
Yeah,
Yeah, you gotta have some Christmas socks on tomorrow, I think,
I
for clinic.
do.
And
I had some I have some of the old SNL skit, the sweaty balls
got
socks. I
it.
have some of those. Um, well, we
Uh,
got a little bit off topic here.
we are definitely steering away. What's our topic today, by the way?
I think we were going to do orthognathic surgery in a more elderly population or orthognathic surgery in old folks, as we are more amusingly, lightheartedly putting on the screen for anyone looking at a screen.
I see just us on the screen, but yeah,
That's all
Josh
you're
surgery
seeing?
in old people. Um, did you ever learn what the definition of an old person is in relation to jaw surgery?
No, I don't know ever remembering a threshold for that. I know as we were discussing things before we came on, you had one in mind that you've come across, I think, in the literature or otherwise that you had, but I don't really ever remember that being something that we focused on, gave much consideration to in general.
Well, because I mean, I think the question comes up when you're talking to people who have malocclusions in teenage years and they don't necessarily have much functional problem with them. Like what would happen if I just left it, right? Like what if I left it, could I just fix what, down the road? And I meet increasingly people who are down the road, right? Like
Yep.
I feel like I more often than not these days see patients that are adult, established into their life, maybe even in retirement. And I'm seeing them for functional reasons, right? Joints don't
Yep.
work, airway, uh,
Teeth, fracturing,
malocclusion.
chipping.
Yeah, exactly. And the concern is, when do the complications start worsening, right? Like, well, when is it? Because it's a big surgery to go through. And from an age perspective, when does it become too risky to go through the operation? And um, I don't know. The way I'd learned is 40. Once you cross over 40, you become old. Um, which I probably when I crossed over 40, I started questioning that. Up till that point, I was probably accepting of that logic. But now that I'm rather comfortably over the age of 40, I don't identify as that. And I mean, in practice, I think there's a different threshold. The I think the 40 and older, there's a paper out of Mass General. I think it was a decade ago. JOMS, Cabin, I think was the senior guy on it. And they looked at complications in 40 and older versus under 40. And I think length of stay, hospitalization, length of stay, and uh, complications from the surgery were all higher in that group. But I feel like, do you feel like that's true? You think like 41 versus 38, 45
Uh,
versus 35?
yeah, I mean, I think when you get more extremes there, yeah, maybe a little bit. I mean, I think it's really when you get to the frailty, the older, I mean, I think from a complication standpoint, I don't know that I see a whole lot more in that regard. I mean, I guess the more as I process it, I would say, I do find that the recovery from nerve injury, I feel like that is a real phenomenon
Yeah, nerve
between
injury,
young and
bone
old.
healing. I mean, on a different hat, let's say TMJ replacement, right? Like you're talking to someone in their 20s or 30s, and you can make a good case for joint replacement. Should they just wait until they get older? Is that like is it less risky to do it when you're older? Obviously, that's speaking from a place of how long these joints are going to last, but there's also the place of avoiding surgery when you're older. But in your mind for like these elective surgeries that were improving function of breathing or the function of eating, um, when do you think it changes though? Do you think it's I know you were when we were
Yeah, I mean,
talking
I'm
ahead of
trying to
time.
ponder through it. I don't know that I have an age number, but I do find that it's maybe the comorbidities more so than a number for me, other than the extremes. When you start getting late 60s and above, I do feel like people are just more frail, and that's not being insulting. That's just reality.
Sure.
And, I would say I haven't picked up a ton on healing, but yeah, I've certainly run into comorbidities that have be required additional consideration. But I would say those comorbidities tend to come with age. So, in females, postmenopausal females, osteoporosis and other things that tend to come along with that, varying the bone density in those patients. But I don't know, maybe it's semantics. Like I don't attribute that as much to age as the condition. Like if I had a 60-year-old without osteoporosis, I'm probably a little more concerned about the 45-year-old with osteoporosis and not the age, if that makes sense, if I'm explaining my
Yeah, sure.
concerns.
Definitely individual variation. I would agree 100%. Like
But I don't
there's
I would
young
say it's
80 year
mostly that.
olds and old 80-year olds, right? Like
Right,
I think we've
right.
met healthy people that look different than their age. Um, and then vice versa, right? But I don't know. I generally, and this might be not the best rule of thumb, but I've generally thought of this to be more of like a 60 cutoff, like maybe 60. I can get behind 55, 65. I like either one of those numbers, so I've just kind of decided in the middle is a good spot. So I know 40
For
to
what purpose, though?
60.
What utility are you using that number for again?
Well, so more like you really have to demonstrate functional trouble. Does that make sense? To risk the problems that can come up after surgery.
Okay, so you're saying like someone comes to you with purely like it's just a skeletal malocclusion. They've lived with it for 62 and a half years, I guess is kind of what you're
60.
saying.
Yep.
And you're just they're coming to you for, hey, I've had this for 62 and a half years. I was told I needed it multiple points in my life. I really want to fix my malocclusion now. They don't have OSA, they don't have joint problems, they're not wearing out teeth. That's when you're having to like, hey, I don't know that this is right for you or this is appropriate. That's what you're kind of getting at.
Yeah, exactly. So um there's some things that put individuals at risk more than others, and one of those is age. And I appreciate the 40 and over cutoff, but increasingly, especially with sleep apnea patients, 40, 50, I mean, in the Caples paper, the average age was mid 50s. And that thing's 15 years old. So it's pretty, I think, I think it's more common these days to treat older patients than it was. And but yet there's still a cutoff. And so I think when it comes to other surgical data, there's other surgical services like orthopedic surgery or general surgery that, rather routine, their cardiac, do operations in older people. And there is a bit of a cutoff. It's usually about 70, but in terms of mortality risk of surgery, I know that isn't frequently talked about with jaw surgery, but going through a 2 or 3 hour anesthetic, or in your case, 5 or 6 hour anesthetic, is different in your 70s, and how
Sure.
much people can tolerate hypotension. Because I don't know about you, but my anesthesiologists at the hospital push back more on hypotension than they have in the past. And so the blood pressure that they're used to living with, how much they're comfortable decreasing, things like watershed strokes happen, right? I mean, there's real things that come up from hypotension that you're just a more risk for after a certain time. And so from just the mechanics of going through it, I think, talking with orthodontics, in adults is different, but it's the same as what we're talking about, orthodontics in your 40s versus orthodontics in your 60s. I think it's just a longer process. And so um, I would say at least a general rule of thumb that I use is about 60 for most times. So meeting with people, like you were saying, I just have a malocclusion. I just never got around to fixing it. I recently retired. Now I can do it. Um, I really want to talk to them about the reasons why not to do it, because I do think it's different.
Yeah, for sure. I mean, I would also throw as an aside, this may derail us a little bit. I just want to kind of mention it, but I have found that as I got out in practice, when I started, as you mentioned, you started seeing those patients come back. I found that kind of reassuring and refreshing because I think the analogy in our world is wisdom teeth, right? Because you kind of tell everyone
Yeah,
you should probably have these out.
it
Here's the
was a great
problems
idea.
that you may have when if you don't, and then in your career, you'll see people start to come back and you're like, those problems I told you about are actually real. But like when you're a new surgeon
Yep.
or a resident, you don't really know that. Like you just know what you're told. Like, hey, these could be a problem. But when you start to actually see those things happening, I always found it refreshing because it's like, okay, what we're telling people is true because I've seen that in jaw surgery. We tell the teenagers that, hey, here's what could happen. You might wear out your teeth. That might be what we're talking about, or you might start cracking and breaking teeth in your 30s, 40s, 50s. And then as you practice more, you start seeing that age demographic come back for those reasons. And it's kind of, you don't wish that on them, but it's kind of validating and refreshing to kind of say, okay, what we've been trained to tell people is in fact real. We can't predict who will and who won't, but it's not like we're just making this up. Have you, is that kind of what you were getting at
Yeah,
earlier? Do you
no,
see that?
absolutely. I mean, because there were some situations, I mean, honestly, in training where where I was wondering, do they really need this surgery? Like that, how much are we helping them for real?
Right.
And from meeting the other end of that, which is the older jaw surgery crew, there's real things that come up. It really can affect you. It's just hard to know the individual it's going to affect them. And so from that part, it's always easier looking backward than looking forward. But
Right.
on the extreme, I do think the cutoffs is about that. So
But I mean, that you're saying without other issues. So let's say they have OSA. What do you just like, okay, like, do you do anything different in that subset, or is it just like you accept it because there's a pathology present?
well, because I'm generally think of the biggest issue is healing.
Mhm.
So the healing potential, and then just how long it takes to heal. And that's bone healing, that's soft tissue healing, that's nerve healing, right? When it comes to sleep apnea, there's reasonable data to suggest the airway response isn't as good in older age. So as in, and maybe not on the threshold of 60, but there is muscle laxity that occurs as time goes on. And so the success of MMA in younger people, one of the reasons why that's thought to be higher has to do with better muscle tone and better response to the skeletal changes. But in general, the healing seems to be it. So talking to people about bone healing and nerve healing, bone healing when it comes to the 60 and over crowd, it's just different because as you were saying, osteopenia, osteoporosis comes into play. I know you've been confronted with the question on bisphosphonate use during orthognathic surgery. Those sort of things aren't coming up in your 16-year-old with an overjet. Um, and so it's a bit of a different management strategy when it comes to bony healing. I do think I tend to give people more time these days. So I tend to
Huh.
go 8 weeks on
Yeah, I was gonna
non-chew.
8 weeks, no chewing.
Yeah.
At over what age do you make that cutoff? At 60?
Yeah, so 60 tends to be at reliably, or then anyone who's symptomatic still at 6 weeks. So if they're a little sore at the one of the osteotomy sites, they tend to push them out a couple more weeks these days.
Wow.
And
Huh.
it's not to be mean, because I mean soft diet is eating anything without your teeth. So you can still have like eggs and pancakes, noodles, fish. It's just you can't bite and chew all the good unhealthy stuff. But giving them a couple more weeks because it does take a while to heal. And it's not like bone healing is done in 2 months. But I think in the older patient, I currently have I wait a little bit longer to get back into normal diet. Neurontin is a normal medicine in that group of people. So gabapentin nightly for the first month. Have you fact I think I learned that one from Farrell, who learned that from someone in New Mexico. I forget his name. So anyway, the addition of gabapentin into the postoperative management, because when I've seen dystocia, it's been in this crowd of patients, by the way. The over 60 crowd, I think, is more prone to things like painful sensation after jaw surgery.
Hmm.
Um, the only bone infection I've seen is over 60 crowd. So generally bone healing um, and nerve healing are the big considerations of whether or not to go through it all.
Interesting. Yeah, I mean, I 100% agree with the nerve aspect of things. I think differing in my practice is I mean, I give Lyrica instead of Neurontin gabapentin, pregabalin instead. I give
Yeah,
that to all my jaw surgery patients unless there's a contraindication.
yeah. I
Anytime
mean,
I
it's good reason to
operate,
do it.
yeah,
Sure.
pretty much everyone I operate on, I give that with, some exceptions. So that doesn't change in my practice. But I would say, I don't know. I certainly can recall some patients where I did have them stay on a soft diet longer, but it was similar to what you were saying, where I was seeing clinically, I was seeing things that gave me pause. But I don't know that in a generality, just because someone is a little bit older, I don't know that I've increased their non-chew time. But I also, especially my Sages, I put in two screws in a plate, and that's probably the difference in why you need to do that for your Sages.
Yeah, the single screw, positional screw seems to bother you too much. But yeah, I mean, I think the fixation giving up, I think that's unlikely, but it is a concern about getting back to biting and chewing. And I do generally find that the the sexes are different in the 60 and over crowd, guys versus ladies. They do seem to be a little bit different in terms of troubles that come up. Um, and I think when it comes to giving the site more time to heal, that's generally women. It generally is. Generally, bone is a little bit worse there, but they're also generally more agreeable to such suggestions. Whereas guys over that age, I mean, I feel like they just get back to chewing almost immediately afterwards. Not that I want them to do that. It's just compliance does tend to be a problem for guys in general. And not obviously that's a generalization, but when it comes to kind of the extended non-chew diet, I don't think I get a lot of pushback on that. I think people understand the reason for it.
Is there anything else you do different? Like, do you graft more or less, or do you do
Well, I
more?
tend to graft about everybody these days, so I don't think that changes much. I think the splitting of the mandible, people particularly in the early stages of their career, I wouldn't encourage you to start doing jaw surgery on people 60 and over. That's kind of like your initial surgeries for a lot of reasons. But one of those is the substance of the bone can be difficult to split, but also put back together. Just like holding screws and just, you can run out of real estate pretty quick when it comes to that. And so the substance of the bone, I probably take a little bit more time on the splitting. But it's a bit I don't know. That's a bit subjective, right?
Yeah, I mean, I think there's points to be made in a lot of this that I think that most people with some experience understand, but I think for younger surgeons residents, the bone does tend to be more, so I would maybe less elastic is the best way to put it. Like you can just get splits that just all of a sudden like you're like this is not splitting and then it just like explodes
Yeah,
if
exactly.
you're not careful. And I think that's a little different because you'll be, if you use a spreader or whatever your mode of choice for splitting, you can just be sitting there and you're like, okay, I clearly didn't go through all my cuts. I need to go back or go through it with the osteotome again. And then just all of a sudden you'll squeeze the spreader a little bit more and it'll just like pop.
Yep.
And that could be one, alarming and concerning. And also it can cause instrument slips, other things. I think you have to be a little bit cautious, like you're saying, in those patients for that reason. And, be careful and just kind of be aware of that. I think you mentioned the bisphosphonates earlier. I think our information on that's not great, but from my understanding, unless you've come across something I haven't, there hasn't been a proven association between any anti-resorptive medications and orthognathic or TMJ surgery and Merange, right? Has that been your
Yeah.
experience too?
Yeah. 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 That's my understanding of asking the questions to the people who write the position papers as well as practicing in the world of doing them.
Because I've run into that problem on the opposite end where endocrinologists or other providers managing anti-resorptive medications for my patients, they as practitioners have had concerns over that
Yeah,
in PMJ
sure.
or jaw surgery,
Yeah, because
which
it's
is
dental
not
surgery.
unreasonable. Not,
Yeah, no.
better be cautious, but like at the same time, I think that's good. That's good information to put out into the world is maybe we don't have really good information on studying that specifically, but there's really nothing out there that even case reports when I look of Merange, medication related osteonecrosis of the jaws from anti-resorptive use in orthognathic or TMJ surgery, right? Is that
I don't remember when this was, but I have a life memory of asking I think it was Sal. How do you say his last name? Ruggiero? Ruggiero? It's something like that. Sal. He's a East Coast guy, but he's one of the names on those position papers on anti-resorptive medication. Um, and I'd already up to that point understood the orthognathic risk, but I'd asked him, what do you think about TADS? What do you think about Invisalign orthognathic surgery in someone who's taken bisphosphonate surgery? And I remember him looking at me like that was the craziest hypothetical that would never exist. His opinion was he thinks it's fine, but I don't want to speak for him. When it comes to these sort of things, I think jaw surgery seems to be okay in that subgroup of patients.
well, it's to me, the question, if I could wave a magic wand and get the answer to, it would be specifically interdental osteotomies and things like you're
Yeah,
mentioning,
exactly.
like TADS. Because I think our understanding of the pathophysiology is it tends to be the alveolar bone, not the basal bone. But you're doing, interdental osteotomies and alveolar bone. You're put TADS in that same area, like you're saying. Those would be the exact questions I would want answered.
Yeah,
So
but
maybe you should tell him to get his act together.
no, those guys keep a good eye on that stuff, and I feel yeah, I like generally talking general rather than saying people's names on stuff. So apologize for that. Um, but when it comes to it, I think the bone healing is part of that. Numbness, I mean, numbness when it comes to jaw surgery, if you're talking MMA, what do you say on numbness? Like it's going to happen?
I pretty much tell every patient the same spiel, and I may have mentioned that on the show here before,
Yeah,
is you should 100% expect to be numb. What I do not know is how numb and how long. And so that varies. I would find with experience and my paying a little bit more attention to it that patients aren't always numb as I've gotten a little
yeah,
bit better at this stuff and as I've gotten more volume. And as again, I've mentioned to you, maybe it was on here or not, that I didn't used to necessarily neurosensory test patients. It was more hey, are you numb? Can you feel my fingers? But I
yeah,
didn't get
subjective.
out the 2 point discrimination and sharp and dull pain
Yeah,
like I do that a little more now. So I find that patients aren't always as numb as I think, but I think it's still appropriate to tell them that I fully expect you to be numb. I just don't know how long and how much because If they're not, great. They're happy. And if they are, then it's par for the course. It's not a surprise. They're not anxious over it as much. But I do have that talk of, over 51, that magic number that comes from our best data on these nerve injuries, that
Yeah,
your
that's what I mean.
ability to decrease your ability to recover from a nerve injury after age 51 or after a year, those are the two numerical criteria I generally spit out.
Yeah,
Um,
I don't know what year that was. That was early, like maybe 2012, 2010, something
it
like
was
that.
the 2010 sometime, I want to say. I don't remember when in that decade, but
But nerve repair outcomes, in terms of people recovering from nerve injury to inferior nerve, outcomes of success declined after a certain threshold of age. And I don't, was it 2%, 3% a year, or something like that?
I,
It was a few percent
yeah,
in their data, and it was after 51. And so, what we're talking about is saying 60, maybe the likelihood to get to functional sensory recovery is less. And
yep,
um, I think you would expect people to achieve that. And so if that's a more common thing, that's something to consider, right? So
absolutely. Yeah, I
uh
mean, and I think you have to tell the patients that, right?
for sure.
Because, while I've been surprised throughout my career that patients don't generally don't care too much about the numbness, but you'll meet some that really like really care.
Yep, absolutely.
But I find that's my experience is the majority acclimate well, but you do get these handfuls who really do not handle it well for whatever reason, even if they don't have dysesthesia. Like they
Yeah.
just don't handle the numbness well. But I frequently find at like my 6 month visits for patients that I ask them about the numbness. Like they don't bring it up. Like when you're asking them, how are you doing? What problems are you having? Where do we stand in ortho? Or like what, having the conversation, it's rare to me that patients bring up, oh, hey, I'm still numb right here. It's always I have to bring it up. And if they have it, it's like, oh yeah, I'm still a little bit numb right here. Is that similar for
Yeah, but
you?
um
Maybe that's a little bit off topic of
yeah,
where
on
we're
the
going
numbness
here.
standpoint, I think you're dead on that it really bugs people sometimes. It's just hard to predict who that's going to be. You obviously tell people all along the way when it comes to numbness and paresthesia. I think the older crew though, it's much more prevalent. And I think again, it gets back to having good reason to put people through the operation.
Right.
Um, the the other things, I guess, ahead of time, and I mean, honestly, when it comes to jaw surgery patients, typically they're pretty healthy. Most of the time, pretty healthy. And so the medical optimization while they're going through orthodontics, what can I do to be healthy for surgery? Like what we were talking to Gabby about that, like taking peptides and healthy living. It's a little bit different than the multiple comorbidity 72-year-old severe obstructive sleep apnea patient, right? Like in that crew, it's very much let's get your glucose management improved, right? Like let's like see what we can do about decreasing a few of these medications, managing those around the time of surgery, um, and how we disrupt the baseline based off of diet and steroids and you know whatever we're doing, that's much more of an issue. So I think gearing up the pre-surgical optimization is more of a game in that group of patients. So
Do you do anything different? Like can you think of other factors that you do differently? Not even necessarily intra-op, like preparation or post-op?
I mean, I think generally speaking, the longer healing time, discussion of risk, setting them up medically, um, and obviously I want to have good functional reason to put people through any surgery, but there are people who come through for aesthetic reasons, and I just generally think aesthetically it could be managed in other ways. So
Yeah, I'm trying to think of
patient
other things that
selection,
I would say. What was that last part again?
patient selection, I guess.
Okay.
Yeah.
I'm trying to, just go through my mind as since we decided on this topic about 30 seconds before we hit record. Other things that I do differently. I think the only other things that I can recall in like preparation or recovery that I do differently is that I think I do just changed my talk on support,
Yeah.
like because typically, the typical orthognathic patient that you would think of for a lot of scenarios is the teenage kid or the young kid coming in whose mom is with them and like there and locked in and asking questions. And you just kind of know there's going to be a level of support here, whether you ask for it or not. Like that mom's dialed in. Uh, just like I would be as a parent, maybe. Um, and then with a little bit of the older population, I talk to them about falls. Like, hey, you're going to be on medications, things are going to happen, you're going to lose weight. Occasionally we'll talk about getting dizzy, going from standing up, sitting down. I mean, I don't know how much of those things matter or how often those things happen, but I do think I changed my talks a little bit to incorporate those things.
And
Or,
I think in adult jaw surgery, for sure, a consideration has to do with support. I think you do need help at home. Not like emergent help, but
right.
help with medications, help with food, help with just kind of keeping your mind off of recovery, right? And
Well, the flip of that is the mom. Like, what if it's the mom who's now having surgery and she's got, like in your family, you've got like 9 kids. Like, if your wife had to go under, and have the like an MMA for sleep, like your household would just fall apart.
yeah,
Like, so I mean, you do have to have those talks of like, hey, if you're the one kind of running stuff, you need some help, or everyone needs to hit the pause button and help you for a few
yeah. There's
weeks
a
potentially.
aside like the consistent worst looking patients that are weak are the moms who bring their kids with them. You know what I mean?
Yeah.
Like they're just not taking a break from momming, and you just need to take a break. Like it's really hard to turn that off, obviously, but um it I'm just imagining anyway, that's a hard go. So I think, that's obviously more like maybe 40s type of range of things, but the
Right.
support at home is important because I mean there's definitely people in the 16 over crowd that are living alone, um, are maybe transitioning in one part of their life to another, like retirement, leaving the area. Just there's a lot of like transitions in life to come up on the social side that I think that's a good point to bring up in terms of considering that aspect. Um, so yeah,
What else? You got anything else? I'm trying
I
to rack
think
my
that's
brain
about
for
it. I
other.
mean, I think on the wisdom tooth analogy, I think that's a wise one. I think, taking out impact of wisdom tooth in someone who's 40 versus someone who's 20 is pretty dang different. But I don't think it's that different in jaw surgery. I think 20 to 40 is pretty similar. But
Yeah,
16 above seems like a different thing. So
I
yeah.
could get behind that.
All
All
right.
right. Well, I guess you want to wrap it there.
Yeah, I think that's good. I think I wasn't looking at enough for our background. Where'd you get this sign at? Let's get off my lawn. I need one of those signs.
That
And a
was on the
cane.
interweb. That was just on the
Yeah,
interweb.
that looks. I definitely identify as the old man with the cane right now. Just
I could see that about you.
just hitting some short people, I guess, walking the nail.
Um,
Um,
hitting short people, holiday pants. We have just gone
yeah,
off the
it's all over the
rails.
place. We're back at it next week, right?
Maybe. I guess we'll see. I don't know if there's going to be an audience after this week. But yeah, we'll see. Figure out next week. Keep the emails coming. We do appreciate it. Although I would say the solicitations for things like podcast guests from random people have gotten a little old. I
Yeah.
think I sent you a couple of those, but if they're actual
Thanks.
pertinent topics and not Dr. So and so from India, who's a psychiatrist who could help us on our show, basically people who,
Well, just sales. Like we're just not into sales as
yeah,
I
we're not
think
into
the main.
sales. Yeah,
Yeah, but
that's a good way to put it.
do like bringing people on with different ideas, and so
Yeah, we have had
if
some
you have
good,
interest in that, that's great. We'll
yeah,
definitely have you on.
we've had good
Um,
suggestions for guests from actual listeners that
yeah,
proposed and other people. That has been actually very good. But yeah, keep the ideas coming. Please don't solicit us otherwise. Well, that also sounds bad, but not intending to. The Christmas edition of Down Fracture Podcast.
all
Down
right, man.
Fracture
Well, Merry
Podcast.
Christmas. I'll catch you next week.
All right.
I think we'll all be a bit older then.
Yep.
All right,
Pants
dude.
bigger. All right. See ya.
See ya.